when it comes to the pharmacological management of type 2 diabetes, we know there are now novel anti-diabetes therapies like SGLT2 or GLP-1RA or DPP-4 inhibitors like incretins. And especially SGLT2 and GLP-1RA are believed to have extraglycemic benefits. A number of clinical trials and epidemiological studies have reported significant benefit in terms of better cardiovascular risk factor control in patients treated with SGLT2 and GLP-1RA. And in terms of cardiovascular risk factor control, we mean significant reduction in body weight, some association with better management of systolic blood pressure, and some association with better lipid management. So then the natural question is, in a progressive disease like type 2 diabetes, if we believe that these therapies could be of benefit for holistic cardiovascular as well as glycemic risk factor management, then the natural question comes, when to place these therapies in the pathway of therapy management in patients with type 2 diabetes. We know that the first line therapy well accepted internationally is metformin, and then the guidelines suggest a host of second line as well as third line therapies. Then should at population level we want to realize the great potential of extraglycemic benefits apart from the glycemic benefit from these new anti-diabetes therapies, to be more specific SGLT2 and GLP-1RA, then we have evaluated if early initiation of SGLT2 or GLP-1RA, to be more specifically within 6 months of the initiation of first anti-diabetes therapy, more commonly metformin, is beneficial in terms of clinically achieving risk factor control in terms of blood glucose level, HbA1c, systolic blood pressure, and lipids, and sustain that control over a period of 18 to 2 years post initiation of such therapy. Again, we have used about 3,000 patients from United States who were evaluated on the basis of their use on SGLT2, and about 28,000 people with GLP-1RA with significant median follow-up period of time. And what we have observed, that the people who are getting these therapies as an intensification are receiving at a very high blood glucose level of about 8.6% of HbA1c. And about 70% of them, if not more, already have an HbA1c above 7.5%. And about 50% of them actually have uncontrolled lipids, if not more. Okay. Even although the fact is that about 85% of them are already on lipid modifying therapies. What we have observed, that if we initiate SGLT2 early on within 6 months compared to later initiation, then there is a 45 to 46% higher likelihood of reducing HbA1c to a clinically acceptable limit within 6 months and sustain it over a period of 18 months to 2 years compared to later initiation. In case of GLP-1RA, the observed benefit is 22% higher likelihood of sustaining, maintaining, reducing and managing the HbA1c level. In terms of at least 2 cardiovascular risk factor control, if we initiate these therapies early on, then there is a 34% higher likelihood or odds of reducing or managing at least 2 cardiovascular risk factors within 6 months and maintain that, sustain that over 18 to 2 years period of time compared to later initiation. And this is adjusted for many other confounders, as you can imagine. So what this clearly suggests that there is a need to further evaluate using electronic medical records and other population level data how exactly these therapies compared to other existing anti-diabetes therapies are playing in terms of not only the short-term benefit of reducing the glucose control, but as we know, managing diabetes is not just about glucose but also cardiovascular risk factors. How better we are if we consider such therapies early on in terms of an early holistic management and more efficient proactive management of cardiovascular as well as glycemic risk factor control in a progressing disease like type 2 diabetes.